Welcome to everything. Replantation. Replantation or a reattachment has been defined by the American Academy of Orthopedic Surgeons as the surgical reattachment of a body part, such as a finger, hand, or toe, that has been completely cut from the body. Examples would be reattachment of a partially or fully amputated finger, or reattachment of a kidney that had an avulsion type injury. Replantation of amputated parts has been performed on fingers, hands, forearms, arms, toes, feet, legs, ears, scalp, face, lips, penis, and a tongue. It can be performed on almost any body part of the children. Medical user. Replantation is performed in response to traumatic amputation. Sharp, guillotine type injuries where relatively uninjured surroundings tissue have the best post-replantation prognosis, with a success rate of 77%. Severe crush injuries, multi-level injuries, and avulsion injuries often mangle soft tissue to the point of precluding rejoining of essential blood vessels, making replantation impossible. In such cases, revision amputation of the stem may be necessary. Technique. Replantation requires microsurgery, and must be performed within several hours of the part's amputation at the center of the specialized equipment. Surgeons and supporting staff. To improve chance of a successful replantation, it is necessary to preserve the amputee as soon as possible in a cool, close to the freezing, but not at the or below freezing, and sterile or clean environment. Parts should be wrapped with moistened gas and placed inside a clean or a sterile bag floating in ice water. Dry ice should not be used as it can result in the freezing of the tissue. There are so-called sterile amputate bags available which help to perform a dry, cool, and a sterile preservation. Parts without major muscle groups, such as the fingers, have been replanted up to 97 hours later. Other 12 hours later is typically the maximum schematic time to tolerate. Parts that contain major muscle groups, such as the arms, need to be replanted within 6 to 8 hours to have a viable limb. It is also important to collect and to preserve those amputees which do not appear to be good candidates for replantation. A microsurgeon needs all available parts of human tissue to cover the wound at the stem and prevent further shortening. In cases of multiple amputation, nerves and vessels from a non-replantable part can be used as graft material for a replanted part. The repair of the nerves and vessels should ask, artery and vein, of the amputated part is essential for survival and function. of the replanted part of the body. Using an operating microscope for replantation is termed microvascular replantation. However, vessels and nerves of large amputated parts, e.g. arm and forearm, may be reconnected using low or no magnification. You should ask. In replantation surgery, following macro amputation, e.g. arm or leg amputation, maximal length of the replanted extremely can be preserved by vascular grafts for blood supply and pedicular free soft tissue flaps for defect coverage. Recovery. Patients should recover in an intensive care unit (ICU) for 24 to 48 hours following replantation due to the need for frequent clinical assessment to monitor for signs of replantation failure. The most common and practical clinical assessment tool is temperature of the replanted part, you should ask. It should be at least 31 degrees Celsius. Other physical exam signs include capillary refill and color. Doppler ultrasound should be used to assess arterial blood flow into the replanted part every hour. Maintaining adequate IV hydration helps to ensure perfusion of the replanted part. Aspirin should be taken every day for up to 3 weeks following replantation to reduce the risk of blood clot at the site of the blood vessel anastomosis. Leech therapy can be used to remove blood from the replanted part if there are signs of venous congestion.